Good evening, everybody, and welcome to the UC Berkeley Summit on Public Health and Innovation in the Middle East. I'm Professor Emily Gottrich. I'm chair of the Center for Middle Eastern Studies here at Berkeley, and I'm delighted to see so many of you here this evening. The Center for Middle Eastern Studies, or the CMES, as we call it, for those of you who don't know, is the interdisciplinary hub for Middle Eastern studies on the Berkeley campus, and we're one of 15 federally designated Title VI national resource centers for the study of the Middle East in the United States. The CMES hosts a rich interdisciplinary lecture and film series each semester, supports courses in Middle Eastern languages and topics across departments, promotes advanced research on the Middle East by faculty, students, and visiting scholars, and conducts outreach to K-14 schools and other community partners throughout the Bay Area. We wear a lot of hats at the CMES, but ultimately our mission is to bring people who care about the Middle East together from across disciplines, departments, and institutions. This is one of the reasons I'm so thrilled to be here tonight for this collaboration with the Center for Global Public Health, the School of Public Health, and the Blum Center for Developing Economies. This summit was truly a joint effort, and we are hopeful of continuing to partner with our colleagues in the STEM fields to address issues like public health or climate change or urban infrastructure, all topics of major import in the Middle East today. I'm also, I'll admit, a little out of my depth here. As a historian of the Middle East and North Africa, for whom innovation means the invention of the printing press, my frame of reference is slightly different from that of our presenters this weekend. But when we talk about a given region of the world, multiple perspectives are critical, including perspectives on language, history, and culture. History has shown us that problems cannot be addressed without multiple perspectives, without partnership, or, to return to the theme of this summit, without innovation. With that, I want to introduce the organizer of this event, Dr. Daniel Zogby, someone who has conducted his own study of the Middle East across a startling array of disciplines. Daniel was an undergraduate here at Berkeley, and I think he was even in one of my classes at some point. And he, in fact, graduated from the Middle Eastern Studies major, which I also chair. He received his PhD from Oxford University in International Relations, and he's written quite a good book in that field, titled Indecision Points, which was published last year. However, while carrying out all of this work in area studies and foreign policy, Daniel founded a successful public health startup, Microclinic International, in an effort to approach the treatment of chronic disease in a new way. This summit was Daniel's brainchild, and I'm happy to welcome him to the floor to introduce our keynote speaker, whom we're very fortunate to have here with us this evening. Thank you again to our partners for this event, and many thanks to all of you for being here. We're looking forward to a wonderful couple of days. Daniel?
Well, thank you very much, Professor Gottrich, our wonderful new chair of the Center for Middle East Studies. I'm really grateful for your kind words and introduction. I'm also grateful to you for the opportunity to organize this summit, which really did emerge from your vision, a vision to bring individuals from different disciplines and different fields of inquiry to discuss issues of great importance to the Middle East when we spoke last year. The Berkeley Summit on Public Health and Innovation and the eponymous undergraduate class, Middle East Studies 150, who are present, are truly inter- and multidisciplinary in nature. But this initiative is also something more. It is also a multi-regional initiative insofar as we wish to create bridges between those who study and are practitioners in other regions of the world dealing with analogous, if not the same exact challenges that are faced in the Middle East. We wish to build bridges that can spur true innovation when possible, along with imitation when needed, and especially improvisation where necessary. Today, too many Middle Eastern people's lives and livelihoods depend on it. Too many are suffering unnecessarily from preventable problems with known solutions. There's a story, and I suppose it might be true, that a Palestinian epidemiologist, puzzled by high mortality rates in the Middle East region, a region known for its Mediterranean diet, decided to launch a global study on the impact of personal dietary patterns and behaviors on mortality rates. So this epidemiologist went to France and saw that they drink lots of wine, eat lots of cheese, and smoke quite a bit, and their mortality rates are lower than they are in the Middle East. And then he went to Mexico, and he saw that they drink quite a bit of tequila, they eat lots of beans and rice, and yet they still have lower rates of mortality than they do in the Middle East. And then, of course, he came to the United States and saw that here we drink lots of soda, sugar-sweetened beverages, eat lots of fast food, watch lots of TV, and still we have lower rates of mortality than they do in the Middle East. So he went around the world basically and did this exercise in every country and saw similar observations. And then after doing a very sophisticated statistical analysis, he presented his breakthrough conclusions at a major public health summit in Washington, D.C. And what were his conclusions? He said, eat, drink, and do whatever the heck you want. It's living in the Middle East that kills you. Sadly, there is some truth to this humor. Today, the current atmosphere of violence and political disorder sweeping the Middle East and North Africa has led to endemic poverty and a lack of access to basic health services. Two interconnected phenomena. All too often, people are poor because they are unhealthy, and they're unhealthy because they're poor. The region is in need of new ideas and new ways of looking at old problems. This summit will examine the role of innovation in public health as two twin engines of social, economic, and political order, and how they might be deployed in shaping and reshaping the future of this critical world region. Tonight, it is my high honor and distinct privilege to introduce to you a man who has experienced turning around hopeless situations. Having been appointed by President Barack Obama to serve as the nation's top public health diplomat, ambassador at large, and global AIDS coordinator with the U.S. Department of State, prior to his current role as United Nations Special Envoy and UCSF professor. I should also add he's head of the Institute of Health Diplomacy at UCSF. Professor Goosby showed exactly how a bipartisan effort, supported by international cooperation, and led by the most powerful and wealthiest nation in the history of humankind, could help to turn around one of the most tragic humanitarian crises in the history of humankind. Thanks in large part to Dr. Goosby's efforts at the helm of the President's multi-billion-dollar emergency plan for HIV/AIDS, millions of people received life-saving medication and treatment for a disease that was crumbling families, communities, economies, and entire nations. The idea of an AIDS-free generation is now within reach. In my opinion, non-communicable diseases, notably diabetes, are to the war-torn Middle East what HIV/AIDS is to the war-torn continent of Africa. For that reason, Dr. Goosby and I have put together a paper in the form of a President's Emergency Plan for Diabetes, or PEPD, which is a call for $1 billion investment in the future of the Middle East and North Africa to prevent the worsening of yet another humanitarian crisis before it's too late. Without further delay, would you please join me in warmly welcoming Ambassador Eric Goosby.
It's really an honor to be with you tonight. I think that it's extraordinary that you are focusing on these issues, perhaps before they have had an opportunity to ripen and impact individuals, increasing morbidity and mortality. What I hope to do is kind of give you a context to begin your discussion. It's not exactly on point, but there are many lessons to be learned from HIV/AIDS, TB, malaria as vertical infectious diseases that have impacted millions and remain the leading killers on the planet. I think that what is also clear is that NCDs are crescendoing throughout sub-Saharan Africa, Eastern Europe, and the Middle East, and will become the dominant cause of death, not in 2035 or in 2050, but in 2020 to 2025, so just on the horizon. The other aspect is the large youth bulge that you see in many of these countries as they move from lower to lower middle to middle income countries, that indeed, for reasons that are not fully understood, are presenting with higher rates of hypertension, diabetes, and coronary artery disease, as well as end-stage renal disease. So these challenges and these types of diseases, challenge to the medical delivery system, are really the kind of convergence of our ability to respond and contain the threat that presents. A medical delivery system that does not identify, enter, or retain people in care is not a useful medical delivery system. And the morbidity continues and the mortality continues. Understanding the type of medical delivery system that can sustain the clinical needs of a medical clinic that is following people with NCDs as opposed to infectious diseases becomes kind of the core of that understanding. The need to have an educated healthcare force who know how to diagnose and treat, having a laboratory that can support the diagnosis and treatment, the use of drugs that can cause end organ damage and need monitoring, and a procurement distribution system that can deliver the reagents to the laboratory, the drugs to the pharmacy to maintain the formulary, so those who carry the disease can benefit from the science that's known and get in front of the treatment that's needed. I'm going to go through this quickly, and I'm happy to, at the end, go back and elaborate on any of what we're going to zip through. But my opening statement is pretty much the larger message that I think you're going to get out of this. So just to put HIV in perspective, 34 million people carry HIV on the planet. 27 million of those people live in Africa, the majority in sub-Saharan Africa. In 2002, before PEPFAR became a reality, there were only 50,000 people on the entire continent of 27 million infected that were using antiretroviral drugs. And for those of you who may not be familiar with antiretroviral drugs, they are highly effective. They stop progression in an individual almost completely. So a person taking antiretrovirals does not progress in their own disease. The virus is contained, the immune function is restored and sustained. And it's likely, if you take the antiretrovirals, and as 85 to 90% of people who do respond maximally to it, so the virus is not detectable in your blood anymore, so-called undetectable, you will die from something else. And what you'll die from is probably an NCD. But that pivot into NCDs is not going to occur if people are dying from HIV first, and that's been the reality, certainly in sub-Saharan Africa. The loss of work, the aged population clearly going on, the economy is faltering. In 2001, the UN General Assembly for the first time spoke of a disease as threatening the economic stability of countries, and that could domino into instability as societies and countries could collapse, and that was the modeled trajectory that we were on. The loss of the working age population, 15 to 50, the groups that are most heavily targeted by HIV, TB and malaria for that matter, knocked the economic motor out of the country, and the workforce drops and the economies follow. But it also presented an extraordinary stigma and discrimination that pushed people who participated in high-risk behaviors down underground. So they would not reveal themselves to their family, let alone to their medical delivery system, their institutions. You must consider with HIV, and I think with any disease, because they each carry a perception both in the individual and in the family and society reacting to the individual once the diagnosis is made. That same relationship stays with NCDs as well. So PEPFAR is a remarkable effort. We've never done anything like this on the planet before, to throw a large amount of resources at a disease in 78 different countries. It's $7 billion a year. It's the largest chunk of our global aid. It is the largest amount of money, making the Marshall Plan about twice as large as the Marshall Plan was after World War II. It is the largest health response that the planet has mustered against an infectious disease. And I think the United States and the taxpayers that have put this together should understand that and be proud of the fact that as a reflection of soft power, this is the reflection of soft power that the United States has put out. And it was under Secretary Clinton's and President Obama's mandate that this be funded and move forward. When we started in 2009, there were 1.7 individuals on antiretroviral therapy. President Bush really heroically decided that this was a disease that he was going to focus on and mounted against advice from every corner the effort and launched this. Under President Bush, it started. Under President Obama, it moved to scale. They are now up at 8.3 million people on antiretroviral drugs. At the time when I stopped PEPFAR a year and a half ago, it was at 7.8. 6.7 million men received voluntary medical male circumcision. As you know, circumcision is a prevention intervention for HIV that protects the male from acquiring HIV from the same exposure. Circumcised male has a 67% drop in the likelihood of becoming infected with HIV from the same exposure. And that drop in infectivity also benefits his partners, who are women in most of the sub-Saharan African countries, and we can actually measure and model out the domino effect that moves into women in the same population. A remarkable intervention that keeps on giving. 17 million people receive care and support every year. These are annual numbers. 21 million in priority and populations are reached with prevention interventions that attempt to identify high-risk behavior and target those individuals for prevention interventions. Prevention of mother-to-child transmission, something we've known how to do since 1993, was when the 076 study showed that AZT prevented dropped transmission from a pregnant positive mother to the baby, fetus, by 50%. We now, with 3 drugs, can drop transmission down to about 1.3%, so almost not transmitting. Those who do transmit are because of blood contaminated deliveries. So, a remarkable program. The impact it had is unprecedented in the HIV epidemic in the late 80s, early 90s, beginning in each of these countries. These are the more heavily impacted countries in sub-Saharan Africa. You see a precipitous drop in life expectancy. And this is not subtle, it's huge, 20 years plus. And with the advent of this intervention, along with the Global Fund for HIV, TB, and Malaria, again, a third of which is paid for by PEPFAR and the U.S. tax dollar. You see these numbers flipping in the other direction. New infections, so the number of new infections in each country, the incidence, dropped precipitously during this period. Averaged 35 in 78 countries throughout Sub-Saharan Africa, Eastern Europe, Southeast Asia, the most heavily impacted countries. Averaged 35 drop in new infections, 35%. But it ranged from 12 to 95%. Smaller countries did better. They were up in the higher numbers. This just gives you a regional picture. You can see the light blue shadow for the Middle East and North Africa. Above that, that purple-colored piece is the percent of new infections that occur in that region. So this is not a huge burden of disease, but it is a significant burden of disease. The decline in new infections varies by country. Uganda and Angola, these are the most heavily impacted countries on the planet, actually have gone up. And if people are interested, we could talk about that. HIV in the Middle East. There are only 500,000 reported cases of HIV in the region, but it is the second most rapidly rising number of new infections in the world. So a looming problem, not yet realized, but clearly there. We have a range of 430 to 810,000, but you need to understand that the surveillance is poor or non-existent. So these are guesstimates that are made by UNAIDS and have been made repeatedly over many years, so they get better and better at it. They've been making these predictions since '97. So the modeling has gotten more refined, but it is modeled. Key populations, 54% of these infections are in women. That same number sticks in the United States, in Europe, and in Sub-Saharan Africa. The majority of people newly infected are women. In the United States, the same, it's 54%, and it's African American women who are the new infections. 60% sexual contact, 70% by blood transfusion. They do not check for HIV in the blood. They do now, but they didn't for many years. Injection drug users, woefully underreported at 3%. No reporting for men who have sex with men or any other. So there's a large number there, doesn't add up to 100, that we don't know where and how they contracted. I think that the lack of surveillance is the big message in the Middle East. These are the key populations that vary by location. The people that contract HIV, and just to take a look in the Middle East area, you've got the light blue, gray, black, a tiny green, darker blue, and the kind of a light green color. I just say this to remind us that this is a disease that moves through the population through many groups that define different degrees of risk by their behavior. And as a result, the public health response must acknowledge that and plan to diversify its ability to identify, enter, and retain people in care. You need to have your system come to people. Some will come to you, but most won't. And you need to be clever about how you orchestrate that. The Middle East is no exception. So, with all of that good news, I just want to remind us, and we've heard Ebola with 12,000 people who died from Ebola. Ebola generated $5.7 billion in global response to that outbreak in those three countries for that number of people. And I just say that to highlight the fact that over the last week, we have had 4,600 babies newly infected with HIV, 36,500 adults, 7,000 in young women. and 25,000 deaths in adults over this same week. So this is a problem that is far from contained, although has diminished in its numbers. So I think now flipping into the tragedy of where we are and what we are doing. As we were saying earlier, the ability to allow people to benefit from the science that we know, we don't do. We are not delivering in the context or in the models that we have proven are effective. We don't learn from that work. We have moved forward with an indifference that is startling, even though the numbers are apparent. And I'm very gratified that you, as a department, are trying to understand your role in watching this evolve. The discrepant results around the globe are not just in HIV, they're in every disease you can name, Another infectious disease, TB, 9 million new cases on the planet annually. It kills 1.5 million people every year, about the same number as HIV, but HIV has dropped down to 1.3 this year. So for the first time, TB has exceeded HIV deaths globally. Multi-drug resistant tuberculosis, which is a mycobacterium that is resistant to INH and rifampin. It costs twice as much to treat. It's harder to diagnose, and only half the people that you do treat live. So it's got a 50% mortality rate. The tragedy with TB is that we have known how to diagnose this disease for 50 years. We've had drugs for 30, 40 years that are effective, not to just stop progression of the illness, but to cure it. We can cure TB. In 85, 90% of people who take antimycobacterial drugs in 6 months, they can stop them, never have to take them again. So the problem with TB is even more tragic. Maternal deaths, there is still this huge disparity. 420 per 100,000 in 2012, 20 times the number greater than the risk of a person in the Bay Area, a woman. We have embarked on a attempt to address preterm birth death on a research level with money from Mr. Benioff and the Gates Foundation. The School of Public Health here is intimately involved in many aspects of this work, but it's an attempt to define what interventions, of the known interventions, can we put to bear in sub-Saharan Africa and Eastern Africa to try to change these numbers. There are 17 interventions that we know drops maternal death, but we can't put them together in front of the person, the woman who needs them. We're also going to do the project in the valley, San Joaquin Valley, because the death rates in the valley are comparable to the death rates in Eastern Africa. They're the same. So we've had the tools to reduce morbidity and mortality. We have used them effectively in the West often, but they need to be delivered and used in smarter ways in the developing world. We need to do it quickly. We will move at glacial speed. PEPFAR was an example of a well-resourced charge that is unprecedented. It really was like no other response, and because of that, we were able to engage and move numbers at a global level. We, as a global health community, are complacent, or perhaps that's too judgmental, but used to looking at these numbers year after year and accepting the inevitability of these numbers and not letting it put a sense of outrage in us. Those disparities and inequities that you see in Berkeley, in Oakland, are sitting there equally close to our thinking and our ability to mobilize resources against them. But we, as academic institutions, rarely see that as part of our mission. And it warms my heart that this department is probing and in a self-reflective way to try to better understand what your responsibilities should or could be, and to try to reconcile that with your other missions, which are just as noble and justified, but I think become more relevant when you place it in the context of the population and geography in which you sit. Those disparities are right here. But we're talking about global disparities, and they're much wider as you move abroad, and have been that way for as long as people have measured them. Malaria, childhood diarrhea, and then NCDs like hypertension, diabetes, cervical cancer, all well documented, all over years to see trends. These illnesses have the same stories as we've talked about. We know how to diagnose, treat, often prevent, but we have not engaged our delivery systems to address it. So, the NCDs, low-income countries, premature deaths from NCDs, 1990 to 2025, traveling up. We're at 2015, and you can see the dotted line is predicted to continue to go up at a precipitous rate. Lower middle income, the same. In upper middle income, we're seeing a flattening and a drop. And in high income countries, we're seeing a drop in NCDs, but not in the low and low middle. The opportunity for us to go with the red dotted line versus the blue dotted line is in front of us. Just with what we know how to do and applying those to a population, modeling shows us we can take that curve in terms of millions of percent deaths from that NCD can be flattened and become a negative slope. Just from what we already know. No new technology, but a lot of innovation in using the delivery systems we have creatively. That's where the innovation is needed. Deaths caused by NCDs, low and middle income countries, the same message there. These are the types of diseases in the NCD deaths. Just to show you, 45% cardiovascular, malignancies up close to 20%, pulmonary and mostly emphysematous changes from chronic respiratory diseases. There's a little pneumonia in there, and asthma is there. Then cirrhosis of the liver, GI, neurologic diseases, mental and behavioral disorders. I would say the area that is completely neglected are psychiatric illnesses. We neglect them in our country. We let the law enforcement system be the entry point for our mentally ill and have a kind of conflict between individual civil rights versus safety and compassion in responding to people with mental illness. If anybody has worked in these settings, you see over and over again the horrible way that people don't move through that system, and the inactivity in our kind of institutions to try to repair it, correct it. Global health funding has largely focused on HIV/AIDS. With malaria and TB, remain the main killers, but this is how it breaks down. This is US dollars for other areas: maternal and child health, nutrition, family planning, reproductive health. There is not one abortion that occurs in any family planning program paid for by the United States. It's against the law to fund an organization that does abortions. But we do all the birth control and family planning work, most of it on the planet. The Global Fund for HIV, TB, and malaria, a third of that is paid for by the United States through PEPFAR's appropriation, and it is the largest motor for HIV, TB, and malaria. It's certainly the largest motor for TB on the planet, but does not have an NCD component. It does have a health system strengthening component that countries can decide to access, but almost none have. because the burden of disease is so urgent. Planning bodies feel guilty, kind of diverting money is how it's viewed, to health systems instead of something that specifically is thrown against the disease. What we saw in the 3 countries in West Africa with the Ebola outbreak was an example of 3 systems that had no capacity to respond to the outbreak. And a country that didn't have a surveillance system on the front end, so they didn't know that this was evolving. And once they realized it was evolving, did not call and they were not heard by the global community through the mechanism of WHO alerting the global community, mostly the donors, and that's basically the G7, that they were in need of resources. And because of that lack of infrastructure, everything fell down. Mostly healthcare workers were the largest group who contracted Ebola, which is typically the case in every Ebola outbreak. It's the doctors and nurses who are in front of the patients who first present, and you have a wave of death with them. And that was certainly the case in all 3 countries with this outbreak. And the development of an incubation period for the first time with Ebola presented a protracted infectivity time that allowed others to get infected before they knew they were at risk, and that's why that epidemic outbreak lasted as long as it did. So the health burden in U.S. priority countries, premature deaths, basically the same message, NCDs, and then just comparing it to HIV, malaria, and TB, which is definitely our best data. But it's not just about the money. It's not just about throwing dollars at something. Those dollars need to have a place to land. Where they land needs to be managed and overseen, needs to interact with those who need and depend on those services so they are responsive to the needs of those individuals initially and as they change. We have failed to meet most of the Millennium Development Goals that were just discussed last week and earlier this week in the UN General Assembly. Since 2000 to 2015, having the Millennium Development Goals allowed donors to rally around areas of focus. It did make a huge difference like we'd never seen before these last 15 years in better understanding of what the burden was, what response was having an impact and what wasn't. So a lot of systems grew up out of that MDG challenge. We've now pivoted, as of last week, into Sustainable Development Goals. These are SDGs, and the overarching health SDG, Sustainable Development Goal, is universal health coverage. That goal is the first time the planet, human beings, have ever put universal health coverage, health care for everyone as a achievable goal. We've never done this before. And I think gives a trumpet of attention to the need for health systems to be part of the package because of the emergence of NCDs. And I think that is the challenge that we've got. Global health efforts have not seen the development of enough sustainable programs that have lasting impact. The way we go about developing health responses is putting a health capability in place that actually is stood up while funding lasts, and then when funding recedes, it goes away. We usually do not use the public health clinics and hospitals. We go in often funding a multinational NGO based out of San Francisco, Berkeley, Columbia, Harvard, Seattle are the usual culprits, the Beltway Bandits, organizations like FHI, all of which do excellent work, but do not allow the resources to expand the capacity of the systems that are responsible for the care of those populations, and indeed often rob both brainpower and I would say diminish the authority and toolbox of the ministries of health to continue to own that as their responsibility, or to play the orchestrating role with a bunch of divergent funding lines converging on their country that should go through the Ministry of Health. And the Ebola outbreak again highlighted the problem with that once again. We're in a constant state of emergency. Our development, global health systems work when there is an emergency. You saw that with Ebola, as such as it was. It mobilized billions of dollars over weeks once the alarm went out. And where that money has gone, you cannot say. I was just with the ministers of health from Liberia, Sierra Leone, and Guinea over the last few days in New York. They say that they have somewhere around $10 to $13 million each that has come through their ministries. The entire rest of that bucket of money is sitting in North America in multinational NGOs who mobilized and traveled 6,000 or 7,000 miles to set up new systems, new clinics, new sites, and has not infused itself into, again, expanding the capacity of those countries. So we haven't learned from our failures or our successes. Our monitoring and evaluation is always after the fact. It's not in real time. It rarely, if ever, comes back into budget consideration, changing what happens in the subsequent year. It is only to appease the donor that M&E is done. It is not the tool that it should be to better refine targeting and incorporation of the populations most in need, or in understanding the investment and the outcome and impact that you're buying with it. We have missed all those boats. We need to change the way we think about health systems. We need to apply proven systems and practices rigorously, evaluate the methodologies that are used, and aggressively look for partnerships in country that support those who are responsible for the health care of the population on day one, not just on the day that we're trying to get out of Dodge, as we have an exit strategy. And right now, those types of outreaches into thinking and baton passing and sharing collegial practices and services and I would say equipment does not happen in the way that it could. We could do a whole lot better with what we've got, is another way to say that. And where we should head is to locally owned and sustainable solutions. The health diplomacy and advocacy is kind of the stool. It's got legs that come from academia. The private sector is not utilized. The national and local governments are ignored. We've talked about that. And civil society is almost never, except with a couple of exceptions, and HIV was one of them, engaged in outreach, loss to follow-up, and kind of quality of care dialogues, ongoing dialogues. The health diplomacy and advocacy is there because most of these services are paid by donors, like 70, 80, 90%. Governments are not the main motors of this work for many diseases, for a lot of maternal and child health and family planning programs, immunization strategies. Country budgets do still address that. But putting a cadre of talent that is locally identified, making the links to the Ministry of Health so they have that support. Private sector is terrific at mid-level management, procurement distribution systems. They do it in their sleep. matching a Ministry of Health up with Coca-Cola or Heineken, Unilever, gives them a local partner that can immediately deploy knowledgeable support to work through a management problem, nurturing and training, as well as tightening a procurement distribution system that, when it doesn't work, closes the clinic that day. Field acceleration, resource alignment, and managing science and practice is the three main areas of focus for this to improve. Looking to reduce the time from engagement to self-correcting and sustaining systems in the medical delivery system that you're supporting. Critical for non-communicable diseases. Evidence-based metrics are the tool that is how we talk about it, how we understand it, and those results need to inform policy. Where the number goes up or down, how the disease moves through the population, how we have positioned or not positioned our delivery system in front of that movement becomes the tax. So, donor alignment. Donors need to reboot their willingness to allow their vertical program funding to move horizontally, to go into health system strengthening, and not just be reserved for that specific disease, which is the traditional way it's done. That will require a dialogue with countries at the highest level, the president of the country, the Minister of Health, mostly the Minister of Finance, with whatever donor country leadership is kind of controlling those dollars. They need to come up with a new agreement so the movement of money becomes more reasonable. The alignment of strategy with key industry players is also something that in sub-Saharan Africa is very critical. But the changing the practice, the replicability, the knowledge transfer, the systems best practice sharing, leadership ecosystem, creating a sense of support systems for the Ministry of Health, all things that we've talked about. I've given you a few examples of this where we did this in PEPFAR and at a two-scale level, not just in 10 clinics or in a province, but in a country. Rwanda, Botswana, Namibia, all are great examples of this. Ethiopia is becoming an example of it as well, which is a large country that has moved to scale. Rwanda, a small country, and not the challenge that Ethiopia certainly is, but they have basically taken what is a almost totally funded medical delivery system by donor funded and managed all the definition of unmet need, the prioritization of those unmet needs, and make all the allocation decisions against them. They then report back to the donor and have achieved all of their stated objectives and outcomes in a really breathtaking manner, and is a good example of what we need to do. It is about innovation. It's about understanding the innovation in the context of your delivery system in real time, not an out of kind of removing it in a laboratory, artificial laboratory setting, but developing the tools to study it in the clinic, in the hospital, and that delivery system, not coming up with a new model for every aspect of it, but using what you have to change the way it identifies, enters, and retains people in care. And those types of innovations occur locally. The team solving problems is where the country needs to get to, where an integrated vision of care with an expanded portfolio of services, not just HIV, but now having that HIV clinic also take blood pressures, do weights, check fasting blood sugars, fasting cholesterols, triglycerides, pennies to do that in terms of human resource differences. Laboratory needs to be supported. You need to have medical records because these diseases are chronic and progressive and run the lifetime of the patient. so you'll need to follow them for their lifetime, like you do with HIV. But it's those types of systems that NCDs need that generally the infectious disease medical delivery systems did not create. So that need to move to a more sophisticated clinic with a referral system in place, matched and interfacing with the community, with healthcare workers and outreach workers that allow you to pull people back in when they're lost to follow-up. All those are NCD needs that are now not in place. So it is about defining the determinants of performance and understanding what those are, the investment and the impact you're buying. When you get ministries of health thinking that way, you see a profound change in how they allocate their money, and you see a drop in numbers when they do that. The numbers follow. Different business planning approach, we've pretty much talked about that. Collaborators, a new ecosystem. And I just wanted to end with, it really is about individuals. It's not about the world deciding that they're going to focus on something and doing it. The world is deciding to focus on something to do it because of the individuals who presented the argument. So I want to put fire in your belly that if you are thinking that you can make a difference, you're right. I, in all of my work, have seen individuals come to bear, one, two, make it four, and rarely larger than that, who actually are the core of the idea and move that idea to program. It is desperately needed, and I want to applaud you for bringing this into your setting here and thinking about, as I say, how your department and your academic community can be relevant to what is a global a problem that only the entire global community will be able to solve. So I'll stop there.
Okay, great. Well, thank you very much for that very enlightening presentation. I think one of the interesting things that you mentioned is that mistakes are being made and no one's learning from the mistakes. And I think one of the reasons why we asked you to be here really was so that as we think about some of the real challenges in the Middle East and North Africa region, you know, we can learn across regions from other things that have been done right and other things that have been done wrong. I think one of the first things I'd like to ask is just, you know, why we've selected HIV/AIDS and, you know, sub-Saharan Africa, and what some of the similarities might be with the NCD, non-communicable disease epidemics in the Middle East, and specifically diabetes. In other words, what are some of the parallels? One of the things that you and I had spoken about was the fact that these are both chronic conditions that can be managed, and you know, early death can be prevented, you know, in quite a straightforward way if certain regimes are followed. What are some other potential similarities between the diseases?
Well, you have a chronic progressive disease. They're both chronic progressive diseases. HIV is now a chronic progressive disease, as we talked about. You have a disease that requires a knowledgeable healthcare provider. They have to specifically be trained in how to diagnose and treat it. And the complexity of the clinical manifestations are such that they need to have a significant understanding of pathophysiology and natural history so they can recognize in a patient who does not present the classic signs and symptoms that a textbook may write about. HIV is just like that, so is diabetes. I think you have a disease that impacts every organ. Diabetes is a disease of vessels, and it's about vessels of a certain size, and they impact your brain, your eye, your heart, your kidney, and your nervous system, your peripheral nervous system in ways that are very similar. So on On a pathophysiologic level, there's a lot of pathology that looks a lot like end-stage HIV, one caused by a virus, another caused by elevated levels of blood glucose that cause the same damage to the lining of the artery, endothelial damage, and results in the same plaque propagation, faster aging that you see in HIV and in diabetes. I think the laboratory component, you need a laboratory for diabetic care. It can be in part portable, but the spectrum of disease that diabetes presents in can be outpatient if managed well, but if you don't manage it well, you quickly deteriorate into inpatient admissions because diabetes will take you there. HIV, uniformly, if you do not treat it and diagnose it, treat the opportunistic infection, you saturate your inpatient services. In sub-Saharan Africa, 4 people in the bed, all HIV related, pushing out people with other diseases, not allowing them to be there because they're occupied. It was the norm. And now that the debulking of HIV has emptied the hospitals, they are now filling back up with NCDs. And I think that that same relationship and need for an outpatient and inpatient capability will continue. And they're very much alike in that regard. I think that the stigma is another area that is the same. Diabetics often have problems identifying a mate because the family knows that there's diabetes in the family and there's a higher threshold to want to bring that into a marriage relationship. But also the shame that people feel by having the disease, pushing them away from presenting themselves to the medical delivery system is very characteristic with both diseases as well. They're both expensive to take care of and require an investment from the insurance or the health care that the government is paying for, or that is significant and will bleed a family into poverty. One of the big problems with universal health coverage will be that it not become a drain and increase poverty because people pay for their medical needs. Families contribute to the needs of a loved one. And I think that economic burden is real. Finally, I guess the workforce impact. You know, you still are hitting people usually present with diabetes in their midlife to 30s to 50s. For type 2 diabetes, the children present early with type 1. The pregnant women will present in their 3rd trimester often. But all of those people need to be followed for the rest of their life. And that chronic need for medical capability and monitoring is, I think, a real one. Companies, like they did with HIV, see people with diabetes. Mining companies now, in particular, are now raising their antennae out for having a capability to diagnose diabetes in the workforce so they can identify early before the person gets in trouble, falls out of work, they have to retrain, and adds a cost to their kind of bottom line. So we're seeing all of that.
I think the point that you made about stigma is especially interesting, and for those who are familiar with the Middle East region, not just with diabetes, but for many NCDs, including mental health and cardiovascular history in the family, you tend to see a desire to kind of keep it hush-hush rather than kind of dealing with it openly, because people are worried, as you said, about the prospects of marriage for their children and kind of what it will mean for the family reputation. I think some of the lessons, from HIV/AIDS in sub-Saharan Africa and how stigma for a disease like, AIDS is dealt with are really important for this fight against NCDs in the Middle East. Just kind of moving into another subject that you touched on, which is really about the financial implications of these diseases that we're talking about, and what that does just for the social fabric in general, and also political order. The Middle East is obviously in clear turmoil. There's conflict everywhere you're looking. And it's tempting to say that diabetes or NCDs are not the things that we, the United States or the United States, State Department or even USAID needs to be focusing on. But in some ways, when kind of health systems fall apart, people start losing, their ability to provide for their family, and they start looking for any and all options and any and all political platforms to pursue. And along with that, your experience in sub-Saharan Africa really has not been in the context of peace. It's really been, in the context of a lot of social unrest. And I'm just wondering if you could share a little bit more with the audience about how, you were able to implement a massive program like this in the context of that unrest, and what that might mean for doing a similar type thing in the Middle East.
Well, that's a difficult question. It's hard to do when you have states that are not interested in the response, or are failed themselves and are not able to mount the political will to mobilize resources of their own to support your infusion of resources. Indeed, Democratic Republic of Congo, Central African Republic, Somalia were all in that boat. Angola, coming out of many years of conflict, has had a lot of difficulty, even with the infusion of wealth. In fact, it has distorted their ability to respond, have not engaged in a process that allows for a diplomatic exchange to make an agreement to decide that you're going to work together on whatever problem. We, in those settings with PEPFAR, had to go to non-governmental institutions, NGOs, are your only other alternative, and faith-based organizations that are often in the country and often not in the capital, in the rural areas of the country. So churches that have missionary work that includes a medical component. You need to use those and expand their ability to cover geographic regions. It's a much harder thing to do. You're dealing with more players. There's no unifying kind of government to put the purse string around the effort. And your surveillance systems that you have to stand up so you understand where and what you're doing becomes this transported capability that you parachute in. And once you establish it, you don't kind of hand it off to anybody. It's very tough to work in a failed state. No one does it well. Those entities that do it well are kind of the comprehensive package, like a military effort that can bring kind of everything in at the same moment. Within a couple of weeks, they've got everything on the ground. But I think we need to study how to deal with failed states better. Okay. We do, yeah.
Thinking about the role of the United States, and also not just financially, but also in terms of leadership. Clearly, financially, the United States contributed billions and billions of dollars, the U.S. taxpayers did, to this emergency effort. What would you say has been the involvement of some of the Gulf countries that have vast resources, the Gulf cooperation countries, in contributing to some of these efforts outside of the Middle East, and what are the strategies that you think would be effective in getting them to pay for an emergency plan for diabetes for the Middle East?
Historically, countries in the Middle East, with the exception of Israel, have not given any support to these efforts. Saudi Arabia gave a couple of million, literally a couple of $1 million to the Global Fund, but it is not viewed as something that they want to support. I've been in more conversations with leadership around their willingness to support the Global Fund in particular, and it's not there. The political will isn't there. I think that the support that has come out of the Middle East has been from private individual foundations, small amounts, but significant for one individual to give. Under 100 million type efforts, which you aren't able to do much with $100 million, as hard as that is to believe. You can do a lot with it, but it's not going to solve a problem at scale that needs to cover a country. I think the awareness and willingness, the self-perception of leadership in countries needs to evolve into seeing health and the health of their population as a critical foundation for both their economic and social health as a country. But I would say that these countries have not gotten to that point for the most part. They're not seeing this as something they should do yet.
Very interesting.
Thank you so much, Professor Goosby. You really provided us with systemic analysis of what was failure and successes, and you gave some roadmap for potential future project. And I was very impressed, or especially interested in what you said. It's really not all about money. It's not about the time. We need to make this effort sustainable. And as a physician who came from the Middle East and practicing now in the US, I think the human being investment is the most important. And in order for any effort to sustain and not feeling every time we are on the emergency response, we have to invest in a human being, in people, to trying to really generate a new healthcare system or build on what it is available there, not only as a physician, but in nurses and other really important factors in the healthcare system that are critical to sustain any effort or response to anything there. So is there anything in terms of either in the State Department or the WHO that they are trying to do in partnership with academia to really, I always go back to nurses because I feel that's an element that it is tremendously missed in the developing country there, and if you could shed any light on that, I will appreciate it.
Well, thank you for that question. I think it is about people, too. It is through people and their ability to bring their system along with them that we will realize, I think, the gains that are needed. WHO has many, I would say, WHO will go out and engage an academic institution, have kind of people meet each other and form alliances that often result in common research questions and work. What I would say is that these countries, I think, need to not be focused so much on the esoteric questions, but more on the practical side of the continuum. Not to say that discovery isn't something that we should pursue aggressively. We should, absolutely. But I think the ethical challenge that someone in one of these countries has is, have we applied the science that we know, the systems that we know work, in the places that are in most need? And what's the ethical responsibility there? And I think people don't ask that question. I'm not sure I know the answer, but I think a thoughtful discussion around it would only benefit institutions that may find or feel that they're irrelevant to this growing problem. It is through institutions that the response is anchored. It's not through an entity that comes in and deploys, but is not part of the kind of societal structure. They can do terrific work in an emergency, acutely, but the sustained work needs to be done by those who live there optimally, because that's the most likely strategy model that will keep those services available to the people who need them for the duration of the need, which often for NCDs is a lifetime. So I think we've approached things as emergencies and have not kind of seen the longer term trajectory as quick enough or something that should be funded. I think it is part of the soft power message that large countries that are rich have to do more. So I would hold the rest of the G7 accountable for what aspects of their resources are they putting toward global health type activities as opposed to more military type activities. We're quick to fund and support huge efforts that in a week spend all the money that PEPFAR has spent. Just our activity right now. So these are large numbers, but these are not insurmountable numbers. These are numbers a country with this kind of wealth can support. The rest of the countries in Western Europe are underpowered in terms of their support for all of this activity, have been for many years. DFID in the UK is the one exception to that, but even they, in the last 5 years, have halved their global pot. Australia, Canada, the same. The 2008 recession took a lot of wind out of the sails, and the United States for many years has been standing pretty much alone. And I think that should be something that we challenge. As NCDs rise, I think mobilizing that G7 and the other countries in Western Europe, Saudi Arabia, Japan, China, Korea, South Korea, are going to be critical. As India, as the BRICS get more on their feet, they all need to think of it differently, either in resources or in technical assistance, as the form it takes. But I believe that the universal health coverage is going to cause all of that to kind of hit the fan.
Hi, my name is Cynthia. I'm a fourth-year public health major. And my question for you is, as these countries undergo this epidemiological transition where there's this growing double burden of disease from communicable and non-communicable, how do you integrate protocol and interventions that focus both on the NCDs and the communicable diseases without, ignoring one or the other?
I think that having platforms that are strong enough, like the HIV platform, an HIV clinic has to have all of the elements that we talked about that are needed in an NCD clinic. That we integrate our health services, that we not do a clinic for HIV, a family planning clinic, a maternal and child health clinic, a TB clinic. That's the norm now. We need to put all the services under one roof, cross-train. We need to have nurses and healthcare workers have a deeper depth of understanding of the disease process so they can think about what they're seeing and figure it out. And we need to ensure that there are referral systems in place that put the more complicated problem in front of the more knowledgeable brain. I think the costs are going to be real because you're expanding services, but how much does it cost for you to have a clinic with 3 doctors and 10 nurses and 2 lab techs and a lab and a procurement distribution system that supports it? For that HIV clinic to now take blood pressures, to now draw fasting blood sugars and cholesterols, to keep a record of what that individual's numbers showed, and to follow them with a medical record that allows you to know what you did 3 months ago today. Those are kind of intangible costs. There are real costs in there, but there are things that you can do that don't have a dollar sign just with the substrate you have to work with. We need to figure that out, and through implementation science, understand what those costs are, and make legitimate, concrete decisions as to how we're going to change our investment pattern to create different outcomes on the other end. And it's time that we think through that as this NCD crescendo is mounting up. So I'm optimistic that we will be able to do this because there's really no choice. So the alternative is to allow things to go undiagnosed and untreated. And I think societies for infectious diseases often don't let that occur forever. They do let it occur, but not forever. For NCDs, I think we need to raise the level of awareness and leadership so they are sensitive to this opportunity to kind of nip it in the bud. It's still going to be a difficult discussion. The final thing is invoking and understanding that the countries need to pay for this themselves ultimately, and to be working on what their contribution to the effort is now, so we understand it. There's not one country that has costed out how much they contribute, how much it costs to put a woman on birth control pills, for example, paid for by the country. They wouldn't, in their economic analysis, have figured out what their kind of cost is for each person on birth control pills for a year. That kind of economic analysis, as simple as it is, needs to be done everywhere, so countries understand what their investment is and puts them at a different position in the table with the donor because they know what they're contributing to it, so their skin is in the game. That's the maturation that's kind of occurring right now in the discussions.
Yeah. My name is Mohsen Malikinejad. I'm an assistant professor at UCSF, originally from Iran. So my question is about, actually I have two questions, but I try to put them together so make it one. So when you're showing the slide with the burden of disease associated with NCDs, and you show the blue line, you show we have the technology, we know what works, but what would it take in terms of financial commitment to make it happen? So that's the first question. But related to that is, one of the arguments that has been made about investment in global health has been that it's not only we are doing a good thing, but we are also kind of making ourselves here in the U.S. Secure by investing in health. If you're preventing disease, Ebola in Africa, so we are safer here at home. How that argument can be applied to NCDs when we're investing in health in NCD that is not, the nature of that is not communicable, it's not making us safe?
I'm not sure. If that argument will lend itself to this. NCDs, because of the youth, the NCDs in our country are in 40, 50, 60-year-olds. In these countries, they're in 20 and 30-year-olds. So a different part of the workforce impacted earlier with a disease that will kill them in 15 to 20 years or less untreated, and has an economic consequence that should be modeled out for each country. And you can model it out, as you know, on a local level. So you can see what a province is going to do or a city will do, which makes it more relevant to local political leadership. But that type of thinking needs to be widely available, and we need to talk in those terms now. I do think that the infectious disease is easier to see the threat. And I'd have to think about putting the meat on that skeleton for NCDs. I'm not sure I can as well, but it's a great question. Yeah.
I think just to add to that point, what in some ways we're starting to see in the Middle East is, a breakdown between the traditional categories of a biologically infectious disease and a non-infectious disease, to thinking about it in terms of its social infection, and that these diseases that were traditionally non-communicable are in some ways socially infectious. We know that certain behaviors propagate through social networks. And so I think in some ways, if we could start thinking about the response to diabetes, heart disease, mental illness in terms of not the individual, but their network, their social network, I think perhaps we can also make some progress in the same way that people have been responding to the HIV/AIDS epidemic.
Here's a new program, so we can...
Yeah. So I think on that note, we don't want to keep Dr. Goosby. We still have to thank him once again for his generous remarks.